All right, let me briefly explain what is anemia. Anemia is one of the common diseases in the world, and it is defined as a condition where the number of red blood cells or the hemoglobin concentration in the blood is lower than normal range. It is leading to reduced oxygen carrying capacity of the blood. So, as you can see, the ranges between men, women, pregnant women, and children. Men usually is less than 13 gram per deciliter, while women are less than 12 gram per deciliter. Pregnant women and children are both 11 gram less than 11 gram per deciliter. Now we are talking about pathophysiology. There are three main pathophysiologies here. First is decreased red blood cells production. It could be from the nutrition deficiencies such as iron, folate, and vitamin B12. Second is bone marrow failure. We have two, which are aplastic anemia and medulloplastic syndrome. So, what is aplastic anemia? Aplastic anemia is a rare but serious bone marrow failure disorder where the bone marrow stops producing enough all three types of blood cells, like red blood cells itself, white blood cells, and platelets. While myelodysplastic syndrome is actually kind of familiar with aplastic syndrome, but this one is focusing on clonal bone marrow disorder, where the bone marrow produces dysplastic or abnormalities shape, and this will cause an ineffective blood cells. Third one could be chronic kidney disease, like reduced erythropoietin. Erythropoietin is actually a very important component that comes from the kidneys, and it goes to the bone marrow and it stimulates the bone marrow to produce red blood cells. So if it's reduced, that means your bone marrow will be producing less red blood cells, or could be otherwise like abnormal shape of red blood cells. Second is increased red blood cells destruction. There are two, which are hereditary and acquired disease. Hereditary could be sickle cell, thalassemia, and G6PD deficiency, and acquired disease could be such as autoimmune hemolytic anemia and malaria. Last of the last of the pathophysiologies is blood loss. It could be from the acute, for example, trauma, surgery, and gastrointestinal bleed, and it also could be from chronic, like peptic ulcer, hemorrhoids, and um, heavy trauma. Heavy trauma could be like heavy menorrhoid. All right, now we're talking about IDA plus rare antibody. So what IDA stands for? IDA stands for iron deficiency anemia, and it defines as an insufficient iron to produce adequate amount of hemoglobin. Usually, the range of hemoglobin concentration from 7 to 8 gram per deciliter. And the classification of this IDA is microcytic hypochromic anemia. There are three causes. The first one is decreased intake. Poor diet, which means low in iron, and a person who is a vegetarian if poorly intake. Second is decreased absorption. This could be some kind of diseases or disturbances where the conditions that uh, disrupts our absorption mechanism. Okay, mainly celiac disease or chronic gastritis. Third is increased loss blood cell. Okay, like like chronic blood cell, chronic loss of blood. Alright, the general clinical features are as follows: fatigue, weakness, pallor, dizziness, and short of breathness. But if we go dive into depth into depth of this clinical manifestation, you can see IDA patient would have koilonychia, like a spoon-shaped nails, glossitis, red tongue, angular cheilitis is a cracks at the edge of the mouth or the corner of the mouth, and pica is a type of condition where a patient or a person is craving for non-food like ice or play. Right. In this case, the patient is having the patient has a rare antibody at the same time of having uh, IDA, which iron deficiency anemia. So generally, antibody screening is done during preparing for a transfusion. So there will be developed an allo antibody against a less common red cell antigen. So clinically significant here, it may cause hemolytic transfusion reactions if if it's in, if it's incompatible, and that means the red blood cell will be broken down during the transfusion due to uh, incompatible foreign body. And while having this kind of cases or condition, it will be difficult to find compatible donor units as well. So rare antibodies are anti-Kelly, anti-Duffy, and anti-Kit.
Let me begin with introducing this patient's biodata. Mr. X is a 56-year-old Iban man and he is a Christian by religion. He works as an oil palm farmer and is currently unmarried. He resides in a longhouse and has a history of cigarette smoking. The patient was admitted on the 25th of July 2025 and was discharged on the 31st of July 2025. For the chief complaint, the patient was found unconscious and was brought to the hospital by the Tuai Rumah. Upon admission, he presented with general body weakness, headache, and fever that had been ongoing for 3 days. He also complained of blurred vision. There was no history of shortness of breath, and his pain score on assessment was recorded as 0. Mr. X is medically diagnosed with symptomatic anemia with underlying severe iron deficiency anemia associated with a rare antibody. Symptomatic anemia is a condition in which patients with anemia present with noticeable clinical manifestations such as body weakness, dizziness, headache, and reduced exercise tolerance. These symptoms were found in Mr. X. A significant contributing factor in this case is the presence of severe iron deficiency anemia, IDA. IDA is characterized by low hemoglobin or hematocrit levels and is commonly associated with microcytic and hypochromic erythrocyte as well as a reduced number of red blood cells. The pathophysiology of IDA is closely related to inadequate iron stores in the body. Since iron is an essential component for hemoglobin synthesis, its deficiency results in impaired oxygen carrying capacity of red blood cells. This mechanism explains the patient's presenting symptoms and overall clinical conditions. Moving on to the presenting symptoms, Mr. X has a throbbing headache that gets worse with movement. He also feels dizzy, which could mean his brain is not getting enough oxygen. He also feeling tired and weak all over for the past 3 days. This could be due to low energy levels or poor blood supply. He also gets tired quickly when doing physical activities. This might be because his body is not getting enough oxygen during exertion, and other symptoms such as fever and also blurred of vision.
Next, for the patient past health history. The patient has severe iron deficiency anemia with rare antibody formation due to multiple transfusion. In 2017, He was diagnosed with Guillain-Barré syndrome and currently ambulate with a walking stick. His history also includes degenerative spine disease with L3-L4 disc prolapse and mild spinal canal stenosis, long-standing hypertension, and recalcitrant peptide ulcer disease. He underwent subtotal gastrectomy, complicated by an anterior wall abscess and chronic sinus discharge at the laparotomy site. Additional concern include suspected bilateral glaucoma, early cataract, a history of transient ischemic attack, and multiple hospital admission. And this patient has been non-compliant with follow-up care, including missed cyanocobalamin injection. On assessment, the patient was alert and oriented with full GCS. He appeared fatigued and had generalized body weakness over the past 3 days. He was semi-dependent in daily activities and ambulated with a walking stick. Neurologically, the right lower limb showed marked hypotonia and complete motor loss, while left had mild weakness. Upper limb showed moderate weakness on the right and normal strength on the left. Sensory function was preserved across all limbs. Visually, he reported blurry vision with suspected bilateral glaucoma and early cataract. Gastrointestinal assessment revealed a chronic sinus discharge at the laparotomy site, but no sign of active bleeding. He has a history of subtotal gastrectomy and multiple abdominal surgeries. Musculoskeletally, spinal canal stenosis and disc prolapse contributed to the lower limb weakness and gait instability. Integumentary assessment showed persistent wound discharge, previously cultured Klebsiella pneumonia with no-new skin lesion or pressure injuries. Next, diagnostic investigations were completed to support the diagnosis and guide treatment. First, a CT brain scan was done to check for stroke or bleeding. It showed multiple old small stroke called chronic lacunar infarct, which suggests long-term damage to small blood vessels. Second, a targeted abdominal ultrasound was performed to assess the wound site and any surgical complication. It showed an incisional hernia with bowel loops but no fluid collection. Third, a neurological examination confirmed motor weakness, especially in the right lower limb, with mild weakness in the other limb, and sensation was normal. Lastly, a wound swab was taken from the sinus discharge. It tested positive for Klebsiella pneumonia, a bacteria that helped guide the choice of antibiotic and wound care.
So, the next one is management and outcome. First one is intravenous slow injection of Venofer 200 mg. Intravenous iron injection was given to rapidly replenish iron stores and correct the severe iron deficiency state. This approach was chosen because of the low hemoglobin and the need for faster restoration of red cell production compared to oral iron supplement. And the outcome is the patient's hemoglobin levels gradually improved, fatigue was reduced, and symptoms such as dizziness and weakness lessened over the course of hospitalization. So the next one is nutritional management. High iron diet with foods such as red meats, leafy green vegetables, and iron-fortified cereals combined with vitamin C-rich foods which to improve absorption. And education was also provided to avoid inhibitors of iron absorption such as tea and coffee during meals. And the outcome for this management is the patient was able to maintain adequate nutritional intake, which supported the correction of anemia and helped prevent recurrence after discharge. So next one is medication prescription. The first medication is zinc copper. The dose and frequency for this medication is 1 tablet OD. The function of this medication is to support red blood cell production, boost immunity, and promotes wound healing. Second medication is folic acid. The dose and frequency for this medication is 5 mg OD. The function is to enhance erythropoiesis and assist in red blood cell maturation. So the third one is ceftriaxone. The dose and frequency is 1 gram BD. The function of this medication is to control chronic wound infection and prevent systemic spread. And last medication is amlodipine. The dose and frequency for this medication is 5 mg OD. And the function is to maintain stable blood pressure and reduce cardiovascular strain during anemia recovery.
Nursing care plan. Fatigue related to decreased hemoglobin as evidenced by low hemoglobin count, verbalization of inability to maintain physical activity, lack of energy and lethargy. Assessment. The objective data is low hemoglobin and hematocrit on lab result, which is 6.4. Patient appears weak or fatigued during the assessment. And the subjective data is patient verbalized inability to maintain physical activity, lack of energy, and lethargy. And our goal is patient will verbalize reduced fatigue and demonstrate the ability to perform basic self-care activities independently upon discharge. Intervention and rationale. First, assess level of fatigue, hemoglobin, and oxygen saturation. This is to act as a baseline and monitor progress of anemia and response to therapy. Second, encourage balance between activity and rest periods. This is to conserve limited energy and prevent excessive fatigue. The third one is assist with activity of daily livings as needed but encourage independence. This allows patient to promote autonomy while preventing exhaustion. The fourth one is to monitor signs of hypoxia such as dyspnea and tachycardia. This is because severe fatigue may indicate worsening anemia or oxygen deficit. The fifth one is to promote a high iron diet such as red meats and green leafy vegetables. This is to support correction of anemia and restoration of energy. And the last one is to educate patient regarding energy conservation techniques. This is to reduce energy expenditure while maintaining functionality. And we have evaluated the nursing care plan upon discharge according to the interventions and rationale we have made. And the evaluation is patient verbalize reduce fatigue and demonstrate the ability to perform basic self-care activities independently upon discharge.
The second nursing care plan which potential problem, the risk for falls related to generalized weakness, hypotonia, gait instability, and history of degenerative spine disease. For the assessment part, objective data, hypotonia, right lower limb weakness, gait instability, which is used walking stick, postural hypotension, high for risk score, requires assistance for mobility and toileting. For the subjective data, patient complex of weakness, fatigue, dizziness, difficulty of walking without support, fear of falling, near falls, back pain, and right leg weakness. For the goals, short-term goals, for the 3 days, patient demonstrates self-ambulation with minimal assistance and no falls. In the long term, before discharge, patient ambulates independently with walking aids, maintains balance and remain fall-free at home. For the nursing interventions, first of all, monitor vital signs for hourly, especially blood pressure, to detect postural hypotension. Second, perform regular for risk assessment to identify risk for timely action. Third, assist mobility and provide walking aids to improve stability. Fourth, encourage patients to call for help before moving to prevent unsafe movement. Fifth, educate on fall prevention to promote safety awareness. And sixth, collaborate with physiotherapists to tailor plan to improve strength and balance. For the evaluation, first, patient will ambulate safely with minimal assistance for free in hospital. And second, patient will ambulate independently with walking aid, improve mobility, and remain for free by discharge.
In conclusion, the case of symptomatic anemia with severe iron deficiency anemia complicated by rare antibody formation demonstrates the importance of early recognition, prompt intervention, and individualized care. through intravenous iron therapy, nutritional management, infection control, and tailored nursing intervention, the patient showed marked improvement in hemoglobin levels, reduce fatigue, and regain independence in daily activities. This case highlights the need for a holistic, multidisciplinary approach to ensure both recovery and prevention of recurrence.